Welcome, and this is lecture 25 of the series on fluids and electrolytes. These lectures accompany and explain my book, Manual of Fluid, Electrolyte, and Acid-Based Disorders, a Pathophysiologic Approach to Common Clinical Problems. I am Dr. Mohammad Tinawi. I am a nephrologist in Northwest Indiana. This is the book. I'll provide a link in the description. You can find it on Amazon as an ebook and also as a paperback. We are still on chapter 3, hyperkalemia. We are going to continue to discuss the etiology of hyperkalemia. So the most important cause of hyperkalemia is hyperkalemia due to impaired renal excretion. Here we have two categories: primary renal disease and hyperkalemic renal tubular acidosis. In other words, like I said before, hyperkalemia is usually due to a renal or an adrenal problem. When we are talking about a primary renal disease, we're talking about either acute kidney injury, especially if the patient is severely oliguric, is not making urine, and advanced chronic kidney disease. We're talking stage 4 or 5, or someone already on renal replacement therapy, someone on dialysis. What about acute kidney injury? Hyperkalemia is very common in acute kidney injury, especially if the patient making little or no urine in oliguric patients. Now, in patients with rhabdomyolysis and tumor lysis syndrome, you can find severe hyperkalemia usually requires immediate attention with medical therapy and maybe dialysis. In acute kidney injury, we see hyperkalemia due to direct injury to the principal cells in the collecting tubules. These cells secrete potassium. So if there's an injury, then you don't have potassium secretion, and subsequently you're going to have hyperkalemia. What about chronic kidney disease, CKD? Usually you need someone with stage 4 or usually 5 chronic kidney disease to see hyperkalemia, or someone who's already on dialysis, renal replacement therapy, RRT. In earlier stages, stage 1, 2, and 3, usually we don't see hyperkalemia because the kidneys still can secrete potassium. But if you have another factor, like someone with diabetes and hyporeninemic hypoaldosteronism, they don't make much aldosterone, or someone with chronic interstitial nephritis, someone who's taking a lot of potassium, someone on a potassium-sparing diuretic, ACE inhibitor, angiotensin receptor blocker, salt substitute, then you have more than one factor. You have chronic kidney disease, and now you're challenging the patient with another thing: increased intake, a potassium-sparing diuretic. So you are reducing the kidney's ability to excrete potassium because you're affecting aldosterone, which is the main hormone that secretes potassium. When that happens, you can see hyperkalemia even in earlier stages of chronic kidney disease. Keep in mind that patients with diabetic nephropathy, even at earlier stages of chronic kidney disease, can have hyperkalemia. Why? Because of hyporeninemic hypoaldosteronism. Keep that in mind. I'm going to repeat it in a minute. So we said the main two reasons for hyperkalemia is renal or adrenal. Okay, now when we are talking about an adrenal cause, we're talking about aldosterone. So we are talking about hyperkalemic renal tubular acidosis. As you know, we have proximal tubular acidosis and we have distal renal tubular acidosis. The proximal RTA and the distal RTA cause hypokalemia. On the other hand, the hyperkalemic renal tubular acidosis, what is it going to cause? Hyperkalemia. Well, it is in the name. Now, here when we are talking about hyperkalemic RTA, they are different terminology. I try to choose the least confusing terminology. Now focus on the least because this is a confusing topic. I'm going to try to simplify it. Okay, hyperkalemic RTA. In this RTA, we have impaired distal sodium absorption. So if the sodium does not go in, potassium is not going to go out. So we are going to end up with hyperkalemic, hyperchloremic, normal anion gap metabolic acidosis. Now here we have two categories of hyperkalemic RTA. We have a voltage-dependent RTA and type 4 RTA, or hypoaldosteronism. Let's look at the role of aldosterone again. Aldosterone is going to act on the aldosterone mineralocorticoid receptor. It's going to activate the sodium-potassium ATPase pump. So therefore, sodium is going to go out and potassium is going to go into the cell. But also is going to affect the ENaC, the epithelial sodium channel, which is located on the apical membrane of the principal cell, which is located on in the collecting tubule. Now, with the effect of aldosterone, sodium is going to go in and potassium is going to go out. So this is how potassium is excreted in the principal cells in the collecting tubule. So anything that would affect aldosterone, whether we have hyporesponsiveness, whether we have decreased secretion, whether aldosterone is decreased or we have a medication, doesn't matter. You're going to have impaired potassium excretion and subsequently hyperkalemia. Okay, we said that there are two types of hyperkalemic renal tubular acidosis. It can be either voltage dependent or can be due to type 4 RTA. Now, voltage dependent RTA is also called hyperkalemic distal RTA or generalized distal RTA with hyperkalemia. In this type of hyperkalemic RTA, sodium reabsorption in the principal cells is impaired. Okay, this decreases the lumen electronegativity, and then potassium will not exit the cell, hydrogen will not exit the cell. So what's going to happen? Hyperkalemia and acidosis. This is what's going to happen in sickle cell disease, lupus nephritis, amyloidosis, and obstructive nephropathy. Now, voltage-dependent RTA can also happen as the result of decreased delivery of sodium due to dehydration, acute kidney injury, liver cirrhosis, or heart failure. Same thing, if you don't have enough sodium delivery, then you have decreased lumen electronegativity, and then potassium will not exit. Remember that sodium will have to go in for potassium to go out. If you don't have enough sodium going in, then you're not going to have enough potassium exiting the cells or hydrogen. And in that case, you're going to end up with hyperkalemia and acidosis. So this is the voltage-dependent RTA, okay? So we said, again, hyperkalemic RTA can be either voltage-dependent or type 4 RTA. What about type 4 RTA? Here again, and I apologize, I know it's complicated. You have to listen to it and refer to it more than once. Believe me, I still refer to the classification every time I come across a case. It's not easy. Type 4 RTA is by definition hypoaldosteronism. And hypoaldosteronism can either be due to reduced aldosterone secretion or due to aldosterone resistance, reduced aldosterone responsiveness, okay? So, the first possibility is type 4 RTA due to reduced aldosterone secretion, okay? This is what we see in diabetic nephropathy due to hyperinemic hypoaldosteronism. This is by far the most common type of type 4 RTA, okay? You're going to see a lot of cases, okay? Patients with diabetic kidney disease, even earlier stages, stage 3, maybe with hyperkalemia. Why? Because they have hyperinemic hypoaldosteronism, and this is called type 4 RTA, okay? Now, the same reason, okay, for this kind of RTA can be seen with RAS inhibitors, so with ACEs, ARBs, direct renin inhibitors, calcineurin inhibitors. Calcineurin inhibitors are what? Prograf, tacrolimus, and cyclosporin, and non-steroidal anti-inflammatory medications. Adrenal insufficiency, of course, is going to cause reduced aldosterone secretion. It's not common, but we really have to make a diagnosis. Again, if you just suspect the diagnosis, give the patient normal saline. Usually they're hypotensive, they're in a shock, and give them hydrocortisone. Maybe start with 100 milligram IV Q8 hours. You can save someone's life. Probably you're going to see more adrenal insufficiency in people who were on corticosteroids and now they stop the corticosteroids suddenly, or they weaned the corticosteroids so fast, and then you're going to end up with adrenal insufficiency syndrome. So remember that. Normal saline plus hydrocortisone intravenously. Okay, chronic heparin can cause type 4 RTA, but it's really not common. Even less common is pseudohypoaldosteronism type 2, also called familial hyperkalemic hypertension, also called Gordon syndrome. Here we have hyperkalemia, hypertension, fluid overload, but normal kidney function. Now, the disorder is autosomal dominant, and usually it's due to mutations in the Wink4 and Wink1 kinases. We talked about those when we talked about the aldosterone paradox. I'm going to provide a link to that lecture. And treatment is with thiazide diuretics. Now, we said type 4 RTA can be due to either aldosterone resistance or due to aldosterone decreased secretion. Now, we discussed reduce aldosterone secretion. Now, what about mineralocorticoid resistance or reduce aldosterone responsiveness? So when do we have resistance to the effect of aldosterone? So we do have aldosterone, but there's resistance. So this is what happens with potassium-sparing diuretics like spironolactone, eplerenone, trimethoprim, which is a blocker of the epithelial sodium channel. Okay, remember this on a test question. Someone maybe with a little bit of chronic kidney disease, you start them on Bactrim for a urinary tract infection, and now they have hyperkalemia. Why? Because of trimethoprim. Why? Because it blocks the epithelial sodium channel. So what? Then again, sodium doesn't go out. Sodium doesn't go in, so potassium will not go out, and you end up with hyperkalemia. Pentamidine does the same thing. We have a rare disorder. It's called pseudohypoaldosteronism type 1, not 2, type 1. This is a rare cause of resistance to the mineralocorticoid effect. Here we have hyperkalemia, metabolic acidosis, but we don't have hypertension like with type 2. We have salt wasting nephropathy. This is autosomal recessive and due to mutation in the 3 subunits of the epithelial sodium channel. Now, again, in pseudohypoaldosteronism type 2, which is Gordon syndrome, you have hyperkalemia, metabolic acidosis, and hypertension. With type 1, you don't have hypertension because you have salt-wasting nephropathy. Now, this is a table. It's in the book, and it summarizes everything we talked about. You can take a screenshot, or you can look at it in the book. I'm going to stop here, and I'll see you in the next lecture.